Hello and welcome to this presentation on the Signia Tinnitus Therapies. My name is Matt Palmerow and I'm the National Product and Training Manager for BSHAA. Thank you for joining me today, and please do not hesitate to contact me if you have any questions at all following on from this presentation. The agenda today, we're going to cover through what is tinnitus. We'll cover the Signia notch therapy, the sound therapy, Signia static noise therapy and Signia modulated noise therapy within the sound therapy. Tinnitus is a problem that has been going on for many years, and as we can see, it's something that many people currently present with. This slide is informative because it not only gives us an understanding of tinnitus, it helps us in the consultation. Why? Because many people feel that they're alone in the face of this problem, since although it is increasingly commented on, it's not always talked about. So it's telling people that there are all others that struggle with this issue can help them, even if just a little bit. What is tinnitus? Tinnitus is the Latin word for ringing and is the perception of sound in the absence of any corresponding external sound. Any sound that's perceived in the head without external source is considered tinnitus, and it features varying from person to person. Now, what have you heard tinnitus be called? In the consultation, I've heard everything from tinnitus vacatus, tubuscus, tinea, tetrus, tinnitus, tendinitis. And how many patients have told you I have tinnitus because, and then they mention something that has no relation to hearing at all, such as I ate an onion and it appeared the next day. It's difficult to explain something like this, and it's even more difficult to be the one to tell them that there is no solution or treatment for tinnitus. To begin with, always validate our patients and what they feel. Tinnitus is not seen, but it exists. In general, a prevalence of this symptom is estimated at 10 to 20% in the general population. Tinnitus can present itself in many ways, where it is usually acute, but we cannot assume. Ideally, when the patient arrives, they understand that we'll treat them as a complete patient and not just an ear. This will help them cope with understanding tinnitus. So what are the types of tinnitus? There is the objective type, which usually originates from the middle ear or vascular system and always indicates the need for medical evaluation. And subjective, audible only to the patient. Its perception is modified through neuronal activity generated in the central auditory pathway after peripheral injury. Hearing loss in acute frequencies is considered a predictive risk factor, and evidence shows that acoustic therapy can help mitigate effects of this type. A study with Critical Hearing Research Lab and the Tinnitus Clinic at the University of Oregon revealed that the tone of tinnitus falls into two categories, tonal and noise. Tonal tinnitus, a frequency can be identified. Tinnitus type noise, hum, click, sound, static sound, etc. Some patients can go to ENT thinking that they're going to find a cause, and the truth is that it can be one or multiple. So as we can see here, it can be part of changes in part of the auditory pathway, such as earwax, otitis, otosclerosis, Meniere's, acoustic trauma, noise exposure. But it can also be changes that affect the ear but do not occur there, such as cardiovascular, pharmaceutical, physiological. But why do some people respond better than others? We can have two tinnitus exactly the same hearing loss, the same tone, etc. But one can say it's just a buzz and it doesn't matter, while the others find it deliberating. And because it varies depending on that patient to patient and what they actually feel from their hearing loss and tinnitus. It's necessary to evaluate it because we need to know how much impact it has and how we are going to know in which category it falls and what type of therapy we may have to use, such as impact on quality of life if they don't fall asleep, and difficulty concentrating will mean that you need to understand what you're adding to the programs to help each individual patient. So let's start with the first of the therapies that Signia offer as part of their hearing aids. The first one is notch therapy. We know from research that the auditory cortex is tonomically organized, meaning that frequencies next to each other on a piano are also processed next to each other within the brain. On the right hand side you can see a picture of a cat's brain. The left side is a normal auditory cortex of a cat, and on the right you can see an auditory cortex of a cat with a hearing loss. Noise exposure and hearing loss cause maladaptive changes in the tonometric arrangement and changes in the neural firing pattern along the auditory pathway. The tinnitus scientific community concluded that some parts of this scientific reorganization goes wrong when you can have frequency band specific hyperactivity when there is lack of sensory input, which can lead to auditory phantom perception of tinnitus. To make it a bit easier to grasp, we can look at this picture of a piano. You can see here all of the keys are the same size, but one key is bigger than the other keys, as a result of some changes along the auditory pathway because of hearing loss or noise trauma, and one part of the neuron network that causes tinnitus is hyperactivity. As you can see at the bottom picture, where all of the input units are the same, but the output units differ where the tinnitus is present. We have a paper from Okamoto dating back to 2010. They did a study where they developed a music therapy which played the preferred music of tinnitus subjects to them. However, they cut out the note around the individual's tinnitus frequency, which they predicted should help through the effect of lateral inhibition that suppresses hyperactive neurons in the cortex and therefore suppress the tinnitus, and this was the main outcome. You can see here that a stronger response from the lateral neurons causes the tinnitus to be less obvious. After reviewing the scientific evidence, Signia applied this evidence to the hearing aids, where we introduce a notch filter into the hearing aid, and this effect of lateral inhibition should also lead to reduction in tinnitus perception. On the bottom right, you can see the notch filter in the 2cc coupler centered around a particular individual with mild to moderate loss tinnitus frequency. The width of the notch is half an octave, and the depth depends on the hearing loss and the fitting, usually roughly 30 dB. The notch therefore blocks out this half octave, as you can see from the 2cc coupler response on the right. To understand the concept of notch therapy a bit better, let's look at this analogy of notch. Imagine the electricity pole represents tinnitus. It is fully visible to the individual with tinnitus. We can try and distract from the tinnitus by putting an obstacle in front of it so it's less noticeable. However, with notch therapy, we push the electricity pole down, which dampens it to become more dull and less noticeable, and with time, the electricity pole simply isn't noticeable anymore. The key here is that notch therapy does take several months to work, and we'll cover this with some research. To investigate the theory of using a notch in hearing aids, a study was performed by the Bosenberg Clinic in the southwest of Germany. 20 participants that were already in the clinic for standard tinnitus therapy, meaning music therapy, tinnitus retraining, or CBT, were recruited. 10 were fitted with the Signia notch filter, and 10 were fitted with a conventional fitting, because we know from literature that hearing aid fitting in itself can be beneficial for the patient. A double-blinded design was used to collect the data, including a TQ12 questionnaires and the feedback from keeping a diary. The TQ12 questionnaire is a short version of the standard TQ52 questions from the Goebel and Hiller that is used in Germany, and it's 70 to 80% comparable to the tinnitus handicap inventory questionnaire. The results were very promising. To the left, you can see the conversion of the TQ12 into a percentage benefit. After 3 weeks, there was a significant reduction for notch group, but not for the conventional fitting. Initial results were very promising. However, this was just 3 weeks in and in a very controlled environment. Another study was performed, and this was the real-world verification over 12 months. This second study was also double-blinded, but this time it was performed in a home trial under the supervision of Dr. Seidler, who was the president of the German Hearing Association for Credibility. The longer version of the TQ questionnaire was used due to the subjects being assessed in real life and researchers wanting to explore all areas that tinnitus affects, such as bad sleep and changes of mood, etc. The prerequisite for this study was that the patient must have had tinnitus for at least 6 months prior and mostly inexperienced with hearing aids, were fitted with Signia hearing aids. Here are some facts about the participants. The main message is that both groups are comparable. This is an overview of the study design, which is basically the same as in the first 3-week study, but most important difference is that we had a total of 6 months therapy overall. Again, roughly half of the patients were fitted with the notch therapy and half received a conventional hearing aid fitting. These are the results. As all the data is published by Harb et al., on the left-hand side you see in the blue the TQ results for the control group and the red for the test group. And this is at the start of the study, after 3 months and after 6 months. If you calculate the post-therapy scores minus the pre-therapy scores, you can see that you get a significant reduction after 6 months on the tinnitus for the notch therapy group. There was a 12.65 TQ52 score after 6 months, which is also a large statistical improvement. You can also see that 15 out of the 19 participants showed an improvement, with one even showing an improvement of 49 points. There is another study by Macrum et al. With an identical study over a 3-month period. The main difference is the frequency had a slightly higher average and the course of the study was shorter. This study showed that patients with longer tinnitus history benefited more from notch therapy, and so did patients with more severe hearing loss. They also benefit more. The study showed that on longer wearing times had a positive effect, but there wasn't the same difference on a group level when comparing conventional with notch therapy. So the treatment group and the control group showed the same amount of benefit. From a clinician's point of view, you can see that combined data for the 2 fittings at the start and at the end, and you can still see there's a benefit over conventional fitting for notch therapy. One of the questions frequently asked is how long does it take for the notch filter to start working? We've just seen a variety in the length of studies, so here is a summary of the findings over the length of time. All the headphone studies were music studies, and then the hearing aid studies I've discussed. As you can see, the longer the study, the better the effects. The shorter the study, the more mixed the evidence is. So we can recommend that the longer patients use the notch filter, it's more likely that they will get a benefit. Another question is who is a candidate for the notch therapy? And of course the answer is that the patient must present with subjective tonal tinnitus, and obviously the tinnitus frequency needs to be within the hearing aid's amplification range. Another important question from an audiological point of view is if the notch will impact speech intelligibility, because a notch is a reduction in gain which usually impacts speech intelligibility. And as you can see from this study, looked at 2 different notch therapies for 20 subjects, And as you can see, there's no significant impact on the speech reception threshold when compared to a normal fitting. The prerequisites for notch therapy is firstly that you need sufficient insertion gain to match the tinnitus pitch, and it is important to have an accurate estimation or match of the pitch of the tinnitus. And if the patient experiences a change in the tinnitus pitch, you would have to rematch the notch. A summary on notch therapy. Signia notch therapy has a good scientific background, not just from our own literature, but also from the literature of others. We have before and after clinical data that supports the notch filter approach. It can be easily embedded in daily life where you don't need extra time for tinnitus therapy, where you need to attend a clinic, and with time, patients will experience relief without adding or masking sound, which can easily be embedded in the clinical practices. You just need hearing aids. To set up the notch therapy in Connex, you must first determine the frequency of tonal tinnitus. You can do this through three methods. Guided matching will play two tones to the patient, and they will choose the tone closest to the frequency of their tinnitus. Connex will then close the gap between the two frequencies presented and until the pitch of the tinnitus is matched. Manual entry works just the same as a hearing test, where you change the pitch intensity until you find a match, or you can simply enter the value of the tinnitus if you've matched it previously. Once you've matched the tinnitus pitch, you will be prompted to perform a frequency check. You won't be able to activate the notch if you've not performed this step. Three tones will be played. One of them will be the pitch that you've matched. Once you've confirmed the frequency by selecting the correct one, you'll be able to activate the notch in the programs you'd like it to be active. The notch will now be visible within Connex. The next option within Signia hearing aids is the Signia sound therapy. Sound therapies have been around for over 50 years, as they were introduced in the 1970s. There is strong evidence to suggest that the sound therapy can provide relief for some individuals with tinnitus, and can also reduce the emotional consequences of tinnitus can cause, such as unhappiness or tiredness. Sound therapy may even promote habituation to tinnitus by reducing the contrast between tinnitus and environmental sounds. There are three main forms of acoustic therapy, which includes amplification, modifying advanced signal processing features, and advanced processing formal tinnitus protocol. Here are some examples of tinnitus pathway for someone with a hearing loss present and someone without a hearing loss. The first line of treatment for a person with hearing loss is of course to fit them with a hearing aid, whereas the first line for an individual with normal hearing would be tinnitus retraining and counselling. The second line of treatment for an individual with normal hearing is cognitive behavioural therapy and counselling, which would hopefully lead to a point where they can manage themselves. Once the hearing aids are fitted, and if more treatment is required, tinnitus retraining followed by CBT will be the second and third line of treatment for individuals with hearing loss. Tinnitus retraining therapy uses a precise and individualized combination of sound therapy together with teaching the individuals about tinnitus and hyperacusis mechanisms to demystify these concepts. Individuals are given directions to how to return or live their life in a way that doesn't provoke tinnitus and hyperacusis symptoms. The sound therapy signal is set by looking for mixing the point where the signal therapy mixes with the tinnitus without masking it. A therapy signal is selected, and then the master gain is reduced until the therapy signal is no longer audible. Then the master gain is increased little by little until the patient says the sound is mixed with the tinnitus. To achieve habituation, the therapy signal should not cover the tinnitus. Both should be heard. Tinnitus activities treatment, or TAT, is a treatment for the reaction to tinnitus that also uses counselling, sound therapy, and other activities based on cognitive behavioural therapy. Counselling can be structured into topics that include thoughts and emotions, hearing and communication, sleep and concentration. For TAT, the therapy signal is set by increasing the master gain handle until the sound is audible and comfortable. The goal is not to achieve total masking, but to a point where it's acceptable for TAT. Many patients report that the broadband noise is easier to listen to. We know from experience that not all patients are candidates for sound therapy. Whilst noise reduction and directional microphones improve sound quality and comfort, but they may encounter productive issues for tinnitus patients. When habituation for treatment is the goal, and we are avoiding silence, alternative amplification strategies may include frequency shaping, whereas a slight increase in soft level gain, reducing noise reduction to optimize environmental sounds as natural masking. Directional microphones can be individualized, as the tinnitus wearer may prefer omnidirectional. Streaming of relaxation sound files within apps. This is a sound therapy trial that was performed in the University of Iowa. 18 adults were subjective, non-pulsatile sensorineural tinnitus participated. The researcher performed 2 weeks of trials, one with the sound therapy and one without. Masking was fitted to reduce the prominence of tinnitus, and it's important to note that no counselling was provided in order to be able to evaluate the sound therapy in isolation. Participants rated the tinnitus loudness, tinnitus annoyance, and accessibility of the background noise using a 0 to 100 interval scale, and the tinnitus primary functions questionnaire was completed. Three of the 18 participants dropped out. 5 of the remaining 15 showed a benefit on the TPFQ score. Sound therapy was observed in areas of sleep, hearing, thoughts, emotions, and concentration. The TPFQ and annoyance data complemented each other well, and the benefit of sound therapy is demonstrated. Signia static noise therapies. They consist of white noise, pink noise, Brownian noise, red noise, low pitch noise, high tone noise, and speech noise. Within Connex, the static noise frequency response can be customized in up to 20 gain handles, and the signal can be activated in monoaurally or binaurally. You can even set the static noise signal different intensities in each program if the tinnitus is more noticeable in one ear. The therapy noise can be mixed with the microphone signal, or a separate noise-only program can be set up as a tinnitus program. We then have Signia Ocean Waves. With Paradise Beach, a new Paradise Beach signal was developed with the world-renowned tinnitus authority Dr. Paul Jasperoff. Not fully modulated, i.e. no silent gaps. A rocky beach, which is also not fully modulated. A boulder beach, similar to the previous sandy beach. And pebble beach. It can be added in one or multiple programs. It's either monoaurally or binaurally. Different intensities in each ear and program. The noise can be mixed with the microphone signal or set up as a noise-only program. And some patients get better results with ocean waves if they have tinnitus associated with stress and used as a relaxation therapy. Thank you so much for listening to this presentation on the Signia Tinnitus programs. If you have any questions at all, please contact me. My name is Matt Palmerow and I am the National Training Manager for WSA. Thank you and enjoy the rest of your day.